Hello friends, today we are going to discuss about the renal replacement therapies and overview of the dialysis modalities. Dialysis therapies involve the movement of the solute and plasma water across the semi-permeable membrane, separating the blood compartment and dialysate compartment. So we will see the mechanism of RRT, the removal of solute and the water using RRT. It may occur by diffusion, convection and osmosis. Diffusion involves the movement of the solute from areas of high concentration to low concentration. Solute molecules have kinetic energy and moves in solution. Small molecules with a greater molecular velocity are more readily cleared than larger molecule, even if both fit through the membrane pores. The high concentration of the solute in compartment favors the high frequency of membrane collisions and passage through the pores. In static system, net transfer ceases when solute concentration equilibrate in the compartment. For RRT, blood and dialysate are repeatedly replenished to maintain the high concentration gradients, favoring the efficient transfer of solute and water. Now, second is the convection. Convection involves the transfer of solute across the semi-permeable membrane, driven by the hydrostatic pressure gradient. Those solute are small enough to pass through the pores are swept along with the water by solvent drag. The membrane acts as sieve, retaining the molecule that exits the pore sides. The filter solutes below the membrane pore size are removed at rates proportionate to their concentration. The convective removal of the fluid in this manner is termed as hemofiltration or sometimes ultrafiltration. This technique does not change the plasma concentration of small solute like blood urea nitrogen, creatinine, electrolyte, and glucose, since water is removed in the proportion to the solute. In contrast, the concentration of larger molecule like albumin and formed element increases as they are sieved off by the smaller membrane pores. Thus, the chemical composition of the filtrate is almost identical to that of the plasma, except for the absence of large molecule like albumin. Now, the third principle is osmosis. Osmosis is the movement of the water from the low to high osmolar solution across the semi-permeable membrane. This physiological principle is utilized into the peritoneal dialysis. Peritoneal cavity is filled with the dialysis fluid with the high osmolarity, which in turn help in ultrafiltration and removal of uremic toxins from the patient. Now we will this is the overview of the dialysis modalities. So we can see it is mainly divided into hemodialysis and hemofiltration. Under hemodialysis, there are three modalities, that is intermittent hemodialysis, that is sustained low efficiency dialysis, and ultrafiltration. So this intermittent hemodialysis works by the principle of concurrent diffusion and convection. Then the next is slide, and the ultrafiltration works by the principle of convection. Now, under hemofiltration, there is a CRRT and the peritoneal dialysis. CRRT includes SCUF, then CVVH, CVVHD, and the CVVHDF. These SCUF works by the principle of convection. CVVH works by the principle of convection, and the CVVHD works by the principle of diffusion with some convection, and CVVHDF works by the principle of concurrent diffusion and convection. Peritoneal dialysis includes continuous ambulatory peritoneal dialysis. It works by the principle of diffusion with some convection. Then continuous cycling peritoneal dialysis works by the principle of diffusion and some convection. Then AVVH, that is accelerated venovenous hemofiltration. It works by the principle of convection. And the AVVHD, that is accelerated venovenous hemodialysis, works by the principle of concurrent diffusion and convection. Intermittent hemodialysis is the standard form of the RRT for majority of end-stage renal disease patients in the United States. During intermittent hemodialysis, the blood is circulated through dialysis machine and hemodialysis cartridge and then returned to the patient, utilizing diffusion and the convection. This is highly efficient modality, provides the rapid solute and the volume removal, but requires both specialized equipment and the trained staff. Both blood and the dialysate are pumped through hemofilter at high flow rate. This dialysate flow is concurrent to the blood flow to maximize the concentration gradient throughout the course of the filter. Diffusion of the solute across the filter is bidirectional. Urea, creatinine, and the potassium moves from plasma to dialysate, whereas the bicarbonate and usually calcium diffuse in the opposite direction. Standard dialysis machine can also perform isolated ultrafiltration that results in fluid removal but does not significantly alter the chemical composition of the plasma. During ultrafiltration, the dialysis machine pumps only blood but not dialysate through the hemofilter. This process generates the hydrostatic pressure gradient across the hemofilter membrane, resulting in convective fluid removal. However, no dialysate is used, there is no diffusive solid clearance. Isolated ultrafiltration is typically used when the volume overload is the sole concern. Fluid removal can be adjusted by changing the hydrostatic pressure gradient between the blood and the dialysate compartment within the hemofilter, an automated process performed by the dialysis machine. Although IHD is used in ICU setting, the rapid shift of the solute and the fluid can precipitate hemodynamic instability and may therefore be less suitable for critically ill patients. IHD treatment are typically performed for several hours, 3 to 4 times per week. However, because the technique is labor and the resource intensive, more frequent treatment may be limited by staffing and cost. Typical IHD session runs for 3 to 4 hours with the blood flow rate of about 200 to 350 ml per minute and dialysate flow rate of 500 ml per minute. Ultrafiltration rates depend upon the patient's hydration and hemodynamic status, but it's generally around 500 ml per. Then next is SLADE, that is sustained low efficiency dialysis. Sustained low efficiency dialysis is the hybrid treatment that provides RRT for extended period of time, typically for 6 to 10 hours, but it is intermittent and discontinuous. So SLADE offers clearance through both diffusion and convection. This therapy attempts to utilize the advantage of slow therapies and minimize the disadvantage of continuous therapies. So SLADE offers the efficient solute removal and delivers the slower ultrafiltrate rate for hemodynamically unstable patients. Its shorter duration offers the advantage like less anticoagulant exposure, lower cost, and decreased nurse overload. It also liberates the patient from the machine for some hours to undergo other important diagnostic and the interventional procedures if needed. Sustained low efficiency dialysis is usually performed using standard hemodialysis machine having ability to set lower dialysate flow rate. The desired flow rate is around 100 to 300 ml per minute. Typically, SLADE sessions run for 6 to 8 hours with the blood flow rate of about 100 to 150 ml per minute. The ultrafiltration rate depends upon the patient's hydration, hemodynamic status, and is generally around 100 to 250 ml per hour. Then continuous and the accelerated renal replacement therapy. CRRT denotes the several hemodialytic modalities that vary in their mode of solute removal and the duration of treatment, but share the characteristic of the slow solute and the volume removal maintained over the extended period of time. Although less efficient than IHD, CRRT provides much higher clearance than the peritoneal dialysis. Like peritoneal dialysis, these techniques are better tolerated hemodynamically than the IHD, since solute and the volume are removed more gradually. These modalities are widely used for the critically ill patient, though they require intensive care monitoring, necessitate ICU admission at hospital with adequate resources and expertise. Now, in slow continuous ultrafiltration, that is SCUF, a pump system maintains the low blood flow through hemofilter and generates the low rate of ultrafiltration, typically 100 to 300 ml per hour. This modality provides the volume removal but does not alter the chemistry of plasma, since the water is removed in proportion to the solute. Compared to the other CRRT modalities, SCUF is low intensity nursing procedure, and the procedure is often used in the setting of severe volume overload with acceptable serum chemistries. This is the diagrammatic representation of the slow continuous ultrafiltration. Now the continuous venovenous hemofiltration. Continuous venovenous hemofiltration uses the convection to solute convection to remove solute through large volume fluid ultrafiltration. Convection sweeps the solute along the fluid independent of their concentration gradient. The porosity of the membrane determines which solute are removed. Small solute molecules such as urea, middle-sized molecules such as inflammatory cytokines are cleared. With larger volume of the fluid removal, intravascular volume must be maintained using replacement fluid. The prescription is based on the patient's serum potassium and acid-base balance. For example, bicarbonate containing fluids are used in the setting of metabolic acidosis or normal saline when significant metabolic alkalosis develops. The replacement fluid can be infused either before hemofilter and after hemofilter. So the post-dilution results is more concentrated blood in filter and higher solute clearance. Nevertheless, more concentrated blood can lead to shorter filter lifespan. While the pre-dilution means the lower solute concentration and clearance, this is offset by high ultrafiltration rate and the longer filter life. Pre-dilution requires the larger volume of the replacement fluid than the post-dilution. Hemofiltration allows the volume removal as well as correction of the electrolyte and acid-base abnormalities based on the selection of replacement fluid. This is the diagrammatic representation of continuous venovenous hemofiltration. Now the next modality is continuous venovenous hemodialysis. It uses the countercurrent dialysate flow to remove small solute by diffusion according to their concentration gradient. Solute clearance can be increased with the high dialysate or blood flow rates. Dialysate contain physiological concentration of sodium, chloride, magnesium, and glucose. Serum potassium can vary significantly in critical illness depending on the factors such as pH, insulin, sympathomimetic drugs, gastrointestinal losses, residual or recovering renal function, and high hemofiltration rate. The potassium concentration of the dialysate is prescribed separately, ranging from 0 to 5 ml. It is not unusual for potassium prescription to change frequently. Dialysate is buffered with either bicarbonate or bicarbonate precursors such as lactate, citrate, or acetate. The use of bicarbonate precursor requires the patient to be able to metabolize them, which can be impaired in liver failure or shock status. Importantly, in CVVHD, there is minimal ultrafiltration and therefore no significant fluid removal. This is the diagrammatic representation of continuous venovenous hemodialysis. Now the continuous venovenous hemofiltration. Continuous venovenous hemofiltration combines hemodialysis, that is diffusive dialysis, and hemofiltration, that is convective dialysis. So ultrafiltrate can be replaced by either replacement fluid as in hemofiltration and countercurrent and co-current dialysate fluid. The choice of CRRT mode is determined by the patient volume status, serum urea, potassium, as well as acid-base balance. So the slow continuous ultrafiltration could be considered in condition with isolated volume overload, such as heart and liver failure, malnutrition, capillary leak syndrome, and in patients who have become resistant to the diuretics. Isolated electrolyte abnormalities can be managed with the hemodialysis, that is CVVHD. Nevertheless, the more critically ill patient received a large amount of intravenous fluid as a part of their resuscitation and ongoing prescriptions and nutrition. This means that those with the kidney injuries usually require ongoing management with fluids and the electrolytes. This can be accomplished using either hemofiltration, using appropriate replacement fluid, or with the hemofiltration, depending on the medical center preference. This is the diagrammatic representation of continuous venovenous hemodiafiltration. Now the next modality is peritoneal dialysis. Peritoneal dialysis is the main form of RRT for approximately 5% to 10% of end-stage renal disease patient. In peritoneal dialysis, dialysate is instilled into the peritoneal cavity. Through diffusion, solute and the volume enter the dialysate, which is periodically drained and replaced with the fresh dialysate. Solute clearance is adjusted by altering volume of dialysate and varying the duration of each dual, the interval between dialysate and the exchanges. More frequent exchanges will enhance the solute removal provided there is sufficient time between dialysate installation and drainage to permit diffusion across the peritoneum. Volume is removed by maintaining high dialysate osmolarity through high concentration of the dextrose. This osmolar gradient results in the movement of the water into peritoneal cavity and contributes to the solute clearance through solvent drag. Fluid removal is adjusted by altering dialysate dextrose content. So PD can be performed as a series of manual dialysate exchange done during the day, that is continuous ambulatory peritoneal dialysis, or through automated exchanges utilizing peritoneal dialysate machine, typically done at night, that is continuous cycle peritoneal dialysis. For continuous ambulatory peritoneal dialysate, dialysate is exchanged every 4 to 6 hours with a longer overnight dwell. For continuous cycle peritoneal dialysis, the exchanges are typically done every 2 to 3 hours through the night, and then the abdomen is often left empty or with only small volume of dialysis during the day. Peritoneal dialysis is much less efficient than the IHD, but is better tolerated hemodynamically because solute and the fluid shifts occur gradually. In the ICU setting, peritoneal dialysis is generally reserved for end-stage renal disease who are already maintained by this modality. Peritoneal dialysis is generally not used for AKI because of the technical challenges with establishing dialysis access as well as low efficiency of solute clearance. Furthermore, the installation of 1 to 2 liter of dialysate into peritoneal cavity can impair respiratory mechanics, particularly in the setting of abdominal distension or EDS. Now, this is the summary of comparison of the different modalities of the dialysis. So, first is cuff, which works by the principle of ultrafiltration. The blood flow rate is 100, and anticoagulation that we are using is heparin. In CVVH, it works by the principle of convection, and blood flow rate is 50 to 300. Anticoagulation that we are using is heparin. Then CVVHD work by the principle of diffusion. Blood flow rate is 50 to 300. Dialysate is 50 to 400. Again, we are using heparin citrate as an anticoagulation. CVVHDF works by the principle of both diffusion convection, and blood flow rate is 50 to 300. Dialysate is 500 to 4000. Replacement fluid is again 500 to 4000, and we are using heparin citrate as an anticoagulation. Thank you, friends.